I'm Daniela Rodriguez, and you are listening to Do or Do Not. In this episode, I am proud to interview Dr. James Aston, DO. Dr. Aston is a Philadelphia College of Osteopathic Medicine alumnus who did a family practice residency at Unity Health in Arkansas and further training in osteopathic manipulative medicine at the University of North Texas. He's also an assistant professor of family medicine at the University of North Texas and runs a family practice and osteopathic medicine clinic. In addition to these accolades, Dr. Aston started the very first Performing Arts Medicine Fellowship at the University of North Texas, where he uses OMM to treat musicians and dancers. Dr. Aston is dedicated to the study of osteopathy, and in an effort to educate students and the public about his passion, has created a podcast, Rolling Bones, where he discusses topics from the history of osteopathic medicine to the intricate details of specific osteopathic techniques. If you are interested in learning more about osteopathy, I highly recommend listening to his podcast. A link can be found in the podcast section of our website. Before we begin this episode, I think it's important to take a minute to define some terms which will be discussed with Dr. Aston. Osteopathic manipulative medicine, or OMM, osteopathic manipulative therapy, or OMT, and neuromusculoskeletal medicine are all synonymous terms that describe the study and practice of the manual techniques that make DOs unique. OMM is not meant to replace standard surgery and medical therapies, but to complement them. Using manual medicine, the physician, or operator, uses his hands to fix somatic dysfunction. Somatic dysfunctions are problems with the body's structure, which when repaired can improve nerve, lymphatic, and blood flow in order to help return internal balance or homeostasis, which in turn will accelerate the body's natural healing process. Some main osteopathic techniques include soft tissue or myofascial release, where the physician massages muscles and superficial connective tissue to release tension. There is high velocity, low amplitude thrusting technique, or HVLA, which is the classic cracking technique, where joints are aligned into their barrier and then forced back into place with quick, forceful movements. There is muscle energy, where the physician engages a point of restriction and uses the patient's own strength to counteract that force, allowing the muscle to relax. And counter strength, where we put the tense tissues into a position of ease to relax tender points. There are also two very specialized techniques which frequently take extra years of study to master, which are visceral osteopathy, which focuses on facilitating the functions of the internal organs, such as the stomach, liver, and heart, and cranial osteopathy, where the operator aims at releasing tension and stress in the body's internal rhythms and impulses, which we can feel with our hands through the patient's head and return their body to a balanced rhythm. I encourage any listeners who are interested in learning more about OMM and how neuromusculoskeletal medicine can be an incredibly helpful and important treatment modality for all patients to listen to Dr. Aston's podcast, Rolling Bones. Although I know that our previous episodes have clearly shown the attributes which make osteopathic physicians special, this interview demonstrates what makes us unique. I really hope you enjoy this interview.
Thank you for having me, Daniela. I am excited to be here on your show today.
I'm excited to have you. Dr. Aston also hosts his own podcast called Rolling Bones, where he talks about all things OMM.
Oh, yeah, absolutely.
And we are here today, and we're going to talk about all things osteopathy with you. My first question, Dr. Aston, is just tell me what your normal day looks like. Start in the morning. What do you do?
Other than the fact that I have 5 kids, so the kids get us up early. In the clinic, it varies from day to day. So I just started a new position as faculty at the Texas College of Osteopathic Medicine at their family medicine residency. So some of my days are spent precepting family medicine residents. At least 2 half days out of the week, I am in the residence clinic helping them take care of patients. And then on top of that, I'd spend some time in the OMM clinic, a couple of half days out of the week there, taking care of straight neuromusculoskeletal medicine patients. And then on top of that, I have my own patients. And we're in the process of developing a performing arts medicine clinic as well. We have one that takes care of music students at the University of North Texas in Denton. They have the largest school of music in the country. They are called the Juilliard of Jazz because jazz is predominant there and a very good program. But I've worked in the past with the Texas Ballet Theater as well, and that was during my fellowship year with performing arts medicine. So it's a wide variety of patients across a spectrum. It's fun.
This fellowship in performing arts training sounds really fascinating. What exactly do you do for the artists?
Performing arts is a very physical job, regardless of what performing art you do. And that can be dancing, whether it be ballet dancing or modern dancing. That could be playing an instrument, whether it be the piano or the piccolo, or using the instrument built into you using your voice. There's a lot of musculoskeletal conditions that come from practicing. And these performers, they practice hours on end nearly every day of the week. So if you're playing an instrument and you're practicing 5, 6, 7 hours a day, and then you have performances on the weekend, it can be very taxing on the body. So this fellowship is an osteopathic based fellowship. Both the program director and the other faculty member are DOs as well. So we spent a lot of time looking at performers from an osteopathic standpoint, trying to prevent injury before it happens or try to get them back on stage safely after an injury happens. So fascinating stuff.
When did you decide that you wanted to go into that?
It was in the middle of my residency for the extra year in O&M. I had never heard of the specialty. I'm a vocalist by my own history, did a lot of singing growing up. And I did a rotation with Dr. Saj the Survey, who is now the program director of the fellowship. I saw what he was doing and said, hey, I'd like to get a little more into this. And so we worked out an opportunity for me to do the fellowship, and here we go. It's amazing.
That sounds really interesting. That's a subspecialty of OMM that I've never really heard of or considered.
Well, and that's because I'm the very first fellowship trained performing arts medicine physician in the world. This is a brand new fellowship, and I was the first person to go through the fellowship. So that's why you've not heard about it. But hopefully, through your podcast, more people will hear about it and get the word out.
So let's go backwards a little bit in time. So tell me, did you know that you wanted to focus on OMM before you even started osteopathic school?
I didn't know what OMM was until I got to OMM lab. So I'm originally from, well, I was a military kid growing up, so I'm kind of from all over the place, but mostly from Utah. And when I was in my undergrad years, I knew I needed to go into medicine eventually, but I didn't know what aspect of medicine. And I went to a lesser known undergraduate school. And it was at that point, I was recommended to apply to both allopathic and osteopathic schools. And I said, osteopathic schools, what's that? And it's another way to get a medical school. Okay, let's do this. When I applied to both allopathic and osteopathic schools. And in reality, I applied to more allopathic schools, something like 11 or 12 of them, and 3 or 4 osteopathic schools. And what's interesting about that whole experience for me was I put PCOM in Philly on there on a whim. I saw it on the list and said Philadelphia. That would be interesting because my wife at the time was applying for a master's degree in piano performance, another connection to the music thing. She had just started her master's program, and we were looking for a place that she could transfer that would have a program for her. And I thought, well, Philadelphia, they've got lots of universities and colleges. I'll put PCOM on there just because it would give my wife an opportunity to branch out as well. And it was a match made in heaven for me. I went to the interview and they were so accommodating and so welcoming. It was not like my interview for the allopathic school I interviewed with. And as soon as I got the acceptance letter from them, which was less than a month after the interview, I knew that's exactly where I needed to go. And off we went a couple of thousand miles from home into a new adventure. It was great.
If we really want in-depth information about OMM, the first thing that I'm going to tell everybody is to listen to Rolling Bones.
Yes, please.
Let's just talk some brief overview definitions. Can you tell me what a somatic dysfunction is?
Somatic dysfunction is when something is off in your body and it presents itself in the musculoskeletal system. So, for example, someone who has asthma and has difficulty breathing, we quite often find in the upper mid back muscle spasms that seem to be associated with it, the asthma. So, we don't call the asthma the somatic dysfunction. The somatic dysfunction is the muscle spasm on the back that's being or associated with the asthma itself. We see this all over the back, the neck, the extremities. The entire body has this potential of these somatic dysfunctions. Now, do somatic dysfunctions always mean there's something else going on? No. So, for example, if you are working out and you cause a muscle spasm that tweaks your back and now you're hurting in your lower back, that somatic dysfunction where the muscle has contracted doesn't necessarily mean that you've got something going on in your colon. It just means that you tweaked a muscle. Another example would be if you catch a joint just such that it gets a little bit out of alignment, but not so much that it's dislocated. And so the joint no longer functions in its normal parameters. It just needs a little bit of adjustment across the joint itself to get it moving again. We do that kind of stuff all the time. I see that with dancers a lot.
So basically, overall, it's like a skeletal muscular manifestation of something wrong within your body.
Yes, that's a very good, more general approach to what the definition would be.
Really was not versed in OMM prior to starting school. We have these basic techniques, these categories. There's soft tissue, there's FPR, which stands for facilitated positional release, and then HVLA, high velocity, low amplitude.
That's where the cracking comes in.
Can you explain just an overview? What do you do? What are they for?
Okay, so if a joint gets stuck, you got to HVLA it sometimes. And keep in mind that the low back and the backbones in general have at least 6 joints per bone, right? They've got the joints for the facets, the joint in between the vertebral bodies, and then as you go up to the thoracic level, there are joints for the rib. These joints are very small. And if they get stuck just a little bit, sometimes the best way to get through that is to just pop it just a little bit. Now, keeping in mind also that HVLA is high velocity, low amplitude. So you're not just cranking on that back. It's a very small degree of motion. Conversely, if you have muscles that are tight, they're hypertonic, they're contracted, you don't pop a muscle, right? You work with the muscle. You soft tissue that you're putting traction perpendicular to the way the muscle runs. Soft tissue is a great and basic technique that really works and people love it. If you have some tissue that's just generally bound up, the soft tissue can work wonders for that. Versus facilitated positional release can also be used for either soft tissue or joints. And in this case, you put the body position into a position where all of a sudden everything releases, and it just takes a few seconds and everything gets better magically. It's magic. There's a couple other basic techniques I like to use. Strain, counter strain, where you have small hypertrophic muscles generally that are tender to the palpation. They're neurologically connected to another region that is out of alignment. You put the body into a position of ease where it feels comfortable and that spot disappears. You know you've treated it. You hold it there for 90 seconds, textbook 90 seconds, and patient feels great. You know, I love how Dr. Jones discovered this technique. Have you ever heard that story?
I have not.
So he had a patient that was not getting better, no matter what he did. And this was back, I think, in the 60s. And this patient keeps on coming back and he's not getting better. And the patient finally comes back for an appointment. And Dr. Jones says, I'll tell you what, I'm really busy today. I've got all of these patients. I'm just going to put you in a position where you feel comfortable and just leave you there. And he leaves him there for like an hour. Comes back and the patient's all better. And he goes, what is this? And he gradually worked on this technique until it came down to 90 seconds. And it works wonders. And then the muscle energy is facilitated positional release with a few modifications of the technique and the time frame needed. But then muscle energy is a popular one in both weightlifting. Physical therapists will use it. They have a different name for it, where you have, again, a contracted muscle that you can either contract that muscle and then stretch it, or you can contract the opposing muscle to get the muscle to release. Those are 2 different approaches. It's a way to get the tissues to release. Great tools.
So we talked a little bit about your practice and your own patients. You said in your podcast that you feel like your family practice is how you identify patients who can kind of benefit from OMM because your true passion really is OMM. So tell me, what percentage of your practice comes to you specifically for OMM and what percentage is general primary care?
I have OMM going on all the time in the OMM clinic, as you can imagine. And in the family medicine clinic, I look for the opportunities to do OMM. Now, you might say, well, of course, anyone coming in with back pain. Well, yes, But what about the people with knee pain? What about the people with hip pain? What about the people with a sinus infection or an ear infection in the kiddos? There are many different opportunities. The first technique I ever saw work was a technique to help someone normalize their bowel movements. And it was amazing. I was doing rib raising on this patient. They got bowel sounds all of a sudden, which was, whoa, that's kind of weird. And their bowel regimen normalized for the first time in years. And I went, whoa, this stuff really works. And I was just a medical student. That was my conversion to OMM was due to rib raising.
That's so interesting. And we talked about, soft tissue and FPR and HPLA.
There was just a review article come out in BMC reviewing craniosacral therapy from a meta-analysis standpoint, and they found great results, actually. I was pleasantly surprised by their conclusions that beyond the fact that it needs more research, because every research project involving OMT always concludes more research needs to happen, but they came to the conclusion that it can be very effective. And since coming to TCOM at University of North Texas, I have begun to use it much more frequently because I have seen some really positive effects, empirically speaking. So yes, it's controversial. There is a number of schools of thought on, especially osteopathy in the cranial field, but there are some positive things that come about because of it. So it's one of those tools that if you don't feel comfortable with using it, you'll still get great success. I wouldn't feel uncomfortable learning more about it.
Where would you even go to get extra cranial practice if you were interested?
There are a couple of cranial academies. There is the Cranial Academy, and then the Sutherland Institute. Both of those would be the places that I would start out. The Arbuckle approach is really easy and not quite as complicated as doing some of the other cranial techniques. So look it up. It's great stuff.
I always feel a little bit lost because it's definitely something that requires a special touch and practice.
It requires experience and getting your hands on heads.
So how do you get DO students to be engaged with OMM?
The only way I know is to get their hands on patients. And I know that's nerve wracking, absolutely worrisome to the students, their first time in the OMM clinic. Oh, you mean I can touch the patient? Yes, you can touch the patient. You can treat the patient? Well, under my guidance, but yes. But what students fail to understand is that primary treatments they're taught in medical school are given to them because they work. Now, I took a bit of a non-traditional approach to postgraduate training. I was an Air Force HPSP scholarship student. And after graduating, I didn't match in any residencies. I didn't match in the Air Force residencies they wanted me to apply for, and they wouldn't let me apply for civilian residencies. So I got into a traditional rotating internship and then was placed in a general medical officer tour, which meant I was doing general practice medicine in the Air Force, active duty. And I went to the Air Force base I was assigned, and they said, well, we don't have a place for you now, so we'll just have to find out something for you to do. And I said, well, I don't have much experience in anything because I'm not residency trained, but I did learn this OMT stuff. Can I do some of that? And the clinic was familiar with it because we had, out of our 8 docs, 6 were DOs. And so they said, well, yeah, we can work with that. And I started using just my basic non-residency trained basic skills that consisted of counter strain, muscle energy, soft tissue, a little bit of HVLA, no cranial at the time. And I tended to see some great results just with the basics. So just getting past the anxiety and fear of putting your hands on patients and getting your hands on patients, you'll find that it can be a very useful tool.
On the other end of the spectrum, do you find that there are students that aren't particularly interested in it? Like they just want to do, neurosurgery and they don't want to do anything else and they're not interested in OMM.
Sure. I expect when you have a class, my class size was 270. I know the class sizes at TCOM are around 230 to 240. When you have that many bright, intelligent, type A personality students, you're bound to have a large majority wanting to do other things. Many go into med school to become neurosurgeons or orthopedic surgeons. Some are wanting to be neurologists or rheumatologists, psychiatrists, palliative care docs. For as many specialties as there are that many students who want to do those specialties. So yes, it makes complete sense that not everyone wants to be an osteopathic manipulation doc, if you will.
Do you think that osteopaths that don't necessarily practice OMM regularly? Do you think that they still have something to gain from their training?
Physical skills and philosophical. I'll never forget. I was flying on a flight into Philly to happen to sit next to a program director to one of the many postgraduate training programs in the city, because there was 5 medical schools and a handful of top-notch hospitals in the area. And this program director told me that they loved getting the DO medical students into their residency programs because they knew the physical exam inside and out and had no trouble with it. So that gave them an advantage in many cases because they were so comfortable getting their hands on patients. I also like the osteopathic approach to look at, we call it the biosocial psychological model, right? Where we're looking at the entire environment that surrounds the patient. We're not just looking at the disease. This patient is not just a diabetic, right? They have a family that has certain dietary needs or expectations. So when you tell them they need to change their diet, if they have a family of 5, you're not changing their diet, you're changing the entire family's diet. And then you have to look at whether or not they're in a food desert and can they afford to make the changes? Can they afford to start exercising or buy the equipment that will be necessary for exercising? And that osteopathic lens that we see the patient in will benefit any physician, regardless of what specialty they choose to train in. And getting that training from early on in medical school changes, I think, the way you approach patients and interact with patients as well. So, yes, orthopedic surgeon can still benefit from going to an osteopathic medical school.
Okay, I'm going to tell that to all of my ortho classmates.
Yes, please do. Ortho can benefit from having a DO that does OMT nearby too. If the patient is non-surgical, yeah, send them to OMT too.
If a pre-med student was interested in OMM, how would you explain it to them?
Well, I think we did a pretty good job of describing what somatic dysfunction is. So I would describe what somatic dysfunction is and then describe how osteopathic manipulations tends to or aims to resolve somatic dysfunction. When the somatic dysfunction is present, that means there's something out of balance within the musculoskeletal system or other systems in the body. And we seek to kind of go Star Wars-ish, restore balance to your forces. Yeah, oh boy. When there are issues in the tissues, we need to restore balance to the forces.
That's the greatest thing I've ever heard. How do you explain the difference between OMM and a chiropractor or a physical therapist?
Well, I tend not to, although I have found that many patients come in expecting a chiropractor. But I will say that chiropractors tend to be focused on joints, whereas our focus encompasses the entire body, whether it be joints or soft tissues. Physical therapists have their own thing as well. They do some OMT they do counter strain and they still call it counter strain. They do muscle energy and they call it a different thing. And I've even seen now chiropractors are doing an alternative, we'll call it an alternative form to fascial distortion model. Have you heard of the fascial distortion model, FDM? It's kind of a new thing. It's only been in the last 20 years it's become popular. And some chiropractors are using that as well. So that's kind of how I go about it. I will also explain that physical therapists do a great job with exercise based programs. They are better than I am developing a therapeutic exercise program or a home exercise program. So I rely heavily on physical therapists to work with me to develop home exercise programs to augment what I'm doing. And I find that I send a lot of my OMM patients get sent to physical therapy if I feel like exercise is going to benefit them. So we really work hand in hand with physical therapists at least. And you'll find in the performing arts side, especially on the dancing side, the Texas Ballet Theater, in addition to the OMT that the dancers are receiving, there are 5 physical therapists that work specifically with the dancers to help them with their core and with their motion and mobility. So, yeah, they are a real valuable teammate, I think, in the neuromusculoskeletal side of things.
So, what do you do if a patient comes in to see you and they're expecting a chiropractor's treatment? What would you tell them?
Well, that is a situation I have never experienced, but I would tell them that I am a physician first and foremost. So that means I can prescribe medications, I can order tests, and I can read those tests that I order. And I can use those tools in addition to the tools that we normally think of, the osteopathic manipulation, to try to restore balance. And as such, I can also refer to specialists, and I think it's important for the patients to understand that I went to medical school and I'm licensed and board certified by medical licensing. So I think that it differentiates us from the chiropractic field for the most part. We do kind of straddle that manual therapy with the Western medicine and other modalities as science warrants their use. So
Do you ever feel like you encounter patients who are a little bit resistant to OMM?
usually the patients that I see in the OMM clinic, we get sent those patients in a specialty setting. So they're already expecting it. Some of the resistance we get will be in the family medicine clinic when they've already been doing all of these other things. And then you say, well, we've got this other thing you can do. Let's talk about it. Some are a little bit wary. Most I've found have been very open. By the time you've tried a bunch of different things and you come to a new doc and he says, well, I've got something else that you haven't tried. Why don't we try it? Most people are pretty well open to it. I've had a few that I tend to frame it in picture in that we're trying to help their body using the body's own mechanisms and not requiring extra medication. And often, as soon as you say, we're not going to give you any extra medications, we're going to do something else, people are pretty open to it. That's a very unique way of viewing the patient, that they have those capabilities of self healing if we can only set up the environment such that it would be optimized for the healing process to go on.
What do you think is the biggest thing that people misunderstand about OMM?
Boy, that's a difficult question. In reality, we as physicians over the last few decades, really after the last century, have spent a lot of time convincing patients that pills are the answer. So when you come at them and saying, well, maybe pills aren't the only answer, that's when you have to do some education. But in reality, I'm finding more and more people are open to going this route.
I think a lot of people like the idea of the easy way out, like just take a pill and make it better.
Right, right. Give me a pill and I'll lose weight. The weight loss pills do have their place, but you can't outrun a bad diet. So, let's look at this differently, right?
So I think, especially with things that have to do with musculoskeletal medicine, a lot of the times pills are definitely not the answer, and it has work and it's physical work and it's things that make you uncomfortable, and people don't love the idea of being uncomfortable.
No, we as osteopathic physicians, we haven't focused on educating the public on what we do and what makes us unique as osteopaths. Now, the AOA has really focused on that recently and done a much bigger social media push and advertising push. But in general, if you go and you walk down the street, and this could be in Philly, this could be in Fort Worth, this could be any, except for maybe Kirksville, which everyone knows what the school is there. You walk down the street and you stop the random person, even in these major hubs of osteopathic thinking and education, and people still don't know what it is. You say, what's osteopathic medicine? They'd be like, what? One of the reasons that we put together our podcast, other than needing to do a scholarly activity for a residency project, is we were trying to get the word out so that the general public can at least have in their mind that there's another thing that can be done. It doesn't have to just be NSAIDs and opiates to treat their pain or surgery or injections.
What is your mission with the podcast? Like, if you had to put it into a sentence.
Unfurl the banner of osteopathy a second time.
I like that. I like that mission. If for whatever reason you just could not have done OMM as your specialty and you had to go back and choose something different, what would you do?
I was up in the air about going to do an OMM +1 residency and doing palliative care. I find palliative care to be very rewarding. And I know that may sound very morbid, but I found that when I was working in the hospitals, one of the things I enjoyed doing was After the patient passed away, I would go in and talk with the family before doing the final exam and learn about the patient and what that patient meant to the family. And hearing the families talk about their loved one was so heartwarming that even in their grief, they could find reasons to be happy.
All right, so this is our grand finale question.
Oh, here we go. We're going to go out with a bang.
Here we go. What was the best piece of advice you got throughout your education and that you pass on to other students?
You know what I like to pass on to my students and residents is you have to take care of yourself. One of the most important things that a physician can do is make sure they are well, because ultimately you're not going to take as good a care of your patients as you could if you're sick, whether that be physical, psychological, social even. We see a large amount of physicians killing themselves. You know, you're probably aware that the suicide rate among physicians is higher than any other equivalent profession. And that's because we don't take good care of ourselves. We give great advice to our patients. You need to exercise. You need to eat healthy. You need to do things that will take care of yourself. And then we don't do that. So setting yourself up for wellness from the very beginning of medical school is going to be the way you're happy. And I also will tell the students that you cannot buy happiness. And what I mean by that is don't choose your job by your paycheck and that you're going to receive. If you're not going to be happy as a plastic surgeon, don't be a plastic surgeon. It's just not worth it. I did have an attending just a couple of years ago said, look, you can make money, but you can't make yourself happy by making your money. You make yourself happy by doing what you enjoy. So do what you enjoy and do it where you enjoy. So if you like to be in a rural situation, yeah, go ahead. Rural medicine is very rewarding. But if you need a city, you better stay around the city, even if that means more expenses involved. But you have to be very careful because you'll get these job offers that'll pay a lot of money. And then you'll get there and they don't take good care of you. They're not worried about you or how well you are. They're worried about the bottom line and how many patients are you seeing and are you meeting their quotas? And if you're not meeting their quotas, you can get fired. So one of the questions that I ask when I interview for jobs is, what do you do for physician wellness? And if they don't have a good answer, then I'm very wary about that. So yeah, take care of yourself before you take care of your patients, because if you don't take care of yourself, you eventually won't be able to take care of your patients.
I love it. And I would expect nothing less from a holistic OMM physician.
Absolutely.
I love it. Thank you so much, Dr. Aston. This has been an absolute pleasure.
Oh, the pleasure is all mine, Daniela. Thanks for having me come on the show. I love what you and your colleagues are doing. Keep up the good work. Get the word out for sure.
And you too, everybody, go listen to Rolling Bones and learn everything there is to know about the beauty that is OMM.
Yes, please. We'd love it.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.